And good morning to everyone. It's my great pleasure to introduce to you our next speaker, Dr. Cournos, Francine Cournos. Dr. Cournos is a professor of clinical psychiatry with a specialty in epidemiology at the Columbia University. She's the principal investigator of the New York and New Jersey AIDS Education and Training Project. Dr. Cournos would have done work in areas of HIV, AIDS, and mental health since 1983, so many years of experience, and has participated in numerous research projects, training grants, practice guidelines, policy development projects. She has participated in international HIV-related mental health projects in Brazil, Canada, Ethiopia, Mozambique, Rwanda, South Africa, Tanzania, and Thailand. Dr. Cournos has edited 2 books and written numerous articles and book chapters on the interface of HIV/AIDS and mental health issues with a particular concentration on people with severe mental illness. Internationally, she has worked on approaches to treat mental health disorders in the context of antiretroviral rollout. Today, she will be speaking on the topic of depression among persons living with HIV, especially given our pandemic situation we're in. Without further ado, allow me to hand over to Dr. Cournos. The floor is over to you. We look forward to your presentation.
Thank you so much. I didn't realize, Tariq, you would be introducing me and that you would give background. So what I have done is just include a little background that says what my work has been, which is throughout different countries, including the Caribbean and Sub-Saharan Africa. And I just want to say that there's something very special about the field of HIV because of the global funding it's received. So one of the things I've learned from working in many different environments is that almost everything you need already exists. So that's been a very important lesson for me when I go to another country, that I don't have to reinvent the wheel, that I usually can find educational resources online, especially if I use not only the peer-reviewed literature, but the gray literature. So everything is there somewhere. That's the main point I wanted to make to begin with. Now, I'm currently involved with the HRSA funded in the US AIDS Education and Training Centers. So I'm going to just say a little bit about the resources available because I think it's good for people to know what they are. So the AIDS Education and Training Centers are sponsored by the US government, and there are 3 national and 8 regional AETCs. And although they're intended for use in the US, they can be accessed globally without cost. So there are a lot of global users of these materials. And I'm the co-principal investigator of the Northeast Caribbean AETC. One of the great things to access, although I don't know that you can get any CME or CEU, whatever kind of credits you get for your education, because this is targeted to the US and its providers, but anybody can use this curriculum, is that David Spock in Seattle, Washington, has created a marvelous national HIV curriculum that anybody can access for free. And it stays up to date. He really works hard. So whatever you want to know about, about new HIV guidelines for treatment, new hepatitis C guidelines, whatever comorbidity there is, he has something about it. And the reason why I'm mentioning that is that it's a great place to go to screen, to look at screens that are clinically relevant for mental illness. So when you go to the national curriculum, you will find a set of instruments that are attached to automatic calculators. That is to say, you can go into any of these instruments and use them on a patient, or for that matter, if you're trying to figure out if you have a disease yourself, use it on yourself, screen yourself for anxiety disorder, depression, PTSD, alcohol and substance use. And again, since I've also done research, these are screens that are really meant for clinical settings where people don't have a lot of time. In addition to the automatic screens, and please interrupt me if you have any questions. In addition to these automatic screens, there's a book chapter. You have to go a slightly different route to get to it, on the sensitivity and specificity of different screens for mental illness and substance use. And that's important to know because a screen isn't really a diagnosis. It tells you if a diagnosis is likely, but not if the person has it. And I can't emphasize that enough when it comes to treating people as complicated as those that have both HIV infection and mental illness. In my own program, we cover New York, New Jersey, Puerto Rico, and the US Virgin Islands. So we are in the Caribbean, but we're in the piece of the Caribbean that is considered US territories, Puerto Rico and the US Virgin Islands. There is an international AETC called Caribbean, it's the Caribbean version of the international program. And I don't think it's currently in Guyana, but it's just maybe worth noting. I think it's centralized in Jamaica and it reaches out to several other countries, but I didn't see Guyana as one of the countries that ITEC reaches. So just something to know about if you wanted to look it up online. Everything in the world, if you have a computer, can be found online. So, in HIV care in the US, and I don't know if you follow a similar continuum in Guyana, I apologize for what I don't know, because normally when I've gone to other countries, I've tried to learn things before I arrive. And I did look at various statistics you have. So, but anyway, we generally follow a care continuum where we're thinking about how do we get people tested? If they test positive, how do we link them to care? How do we retain them in care? Do we start antiretroviral therapy? Do we achieve viral suppression? So that's an organized way of thinking about it. So in my AETC, the Northeast Caribbean AETC, we've done the same thing for behavioral health. So we use the term behavioral health, a term that I hate, but I use anyway, because in the US, most people use that term to mean mental disorders and substance use disorders. Now, substance use disorders are mental illnesses, but for some reason in the US, they're often siloed in a different way, and you can't get care for both disorders in the same place. As a result of the severe and very problematic silos that we have in the US, we have to let people know that we don't mean just things like depression and anxiety disorders. We're also talking about people who are using substances. And if there's anything you want to tell me about Guyana in terms of whether you follow a continuum, and I know you've been funded for it, by various entities, including the CDC for HIV care. So if anybody on is an HIV care provider, please chime in. So everywhere I go in the world, this is my own personal preference. Everywhere I go in the world, I use the same framework. I use the WHO pyramid of mental health services. I have to say that it is enormously useful because almost no country has enough behavioral health providers to treat everybody with a behavioral health problem. You really can't depend on your specialists alone to do it. And I know that's a lot of what this conference is about. How do you reach out when you don't have a lot of behavioral health providers? How do you reach out to rural areas? How do you reach out where there's nobody well-trained in behavioral health? And the WHO pyramid for me is a guiding force. So I'm going to just show you a bigger picture of it. And I'm going to talk a little bit about COVID, just because all of us have had our work disrupted by it. Again, I know you've seen a fair amount of HIV in Guyana, and so have you also seen COVID. So in the US, which is where my main experience is with COVID, we have such a high percentage of our population distressed that we can't possibly send everybody to a behavioral health provider, even though we have, I'm sure, a greater concentration than you do. It's just not great enough. So we've really had to think about this pyramid of services. We've really had to think about how do we reach out to people and encourage them to engage in self-care. And there've been a lot of articles about COVID and healthcare workers showing a tremendous impact on the stress and rates of mental illness in healthcare workers. And so we've been bombarded, in the US at least, with advice about how we're supposed to stay healthy, centered and within ourselves, and so on and so forth. And we also rely on informal community care. So for example, in the African American community, one of the most important centers for support is the church. So there are people in the US who are trying to think about how do we use churches to reach out to people about their mental health problems. And then there are primary care services, because most people, when they initially present to a medical setting, are not presenting to a psychiatric setting. And it's in the primary care services where we have a good chance to detect that someone has a mental illness and make a decision. What level of treatment do they need? Do we try to send them up the pyramid for specialty care? Can we send them, just shore them up with informal and self-care? So it's that primary care level that makes the most important decisions about what to do with people who present. Because at least in the US, the majority of people who present with a mental illness are presenting in primary care. And actually, the majority of psychotropic medications prescribed in the US are being prescribed by primary care clinicians. So the rest of my talk, now that I've given an overview of how I'm thinking about it, is going to look specifically at depression. So when there have been a lot of surveys done about how common depression is in people with HIV infection, and I can tell you that the estimates vary enormously, from a low to 6% rather, to a high of 67% of the population being affected by depression. But in general, if you look globally, research generally shows that depressive disorders are the most common psychiatric disorders seen in HIV clinical care settings. So that's usually the #1 disorder. And in the US, we have tremendous comorbidity problems. And I think some countries have less of that. So I don't know about Guyana, but we often see depression that's complicated by other conditions, like alcohol and substance use disorders, anxiety disorders, post-traumatic stress disorder. So when we're trying to treat depression, we're not only thinking about the depression in terms of the person's mental health, we're really thinking about other things intersecting with the depression. I don't know if anybody would like to make a comment about whether you see a lot of comorbidity. Does anybody want to talk to me? You don't have to.
No, Dr. Cournos, this is amazing. I was just thinking about how this may differ by age groups. I mean, 18 to 24 versus, older groups.
Yeah, so you know what? It does vary by age groups. And, and with substances. So for example, one of the things that always struck me in the US is that injection drug use with opioids is something that you see more in a younger population, and people tend to stop using it as they get older for reasons that are still mysterious to me. Whereas alcohol is the most frequently used substance, and although perhaps older people might do less partying and binge drinking, there's still a lot of alcoholism dependence in older populations.
Well, I've thought a lot about that, and I think it's about emerging adulthood. That's supposed to be a time of independence and gathering thoughts, but it's very different than someone that's settled, that has a family that lives with HIV.
No, I think that's a very good point, and I completely agree with it. I think one of the reasons why I'm not specifically focusing on that emerging population is that in the US, we have an aging population of people with HIV, and that's become a big focus because as people have survived longer, And again, I don't know about lifespan in Guyana, but in the US, as people have survived longer, more than half of our HIV patients are now over the age of 50. So I think you're right to look at the younger population in terms of risk behavior, because you're right, in emerging adulthood, you're seeing the most risk for acquiring HIV. But then when it comes to people who already have established HIV, there you're dealing with an aging population. So prevention is, I think we're thinking much more younger people. Care, in many ways, we're thinking about the older population. Does that make sense?
Absolutely, point well made. I mean, yeah, it's a different thing to put onto your research and stuff about how it may differ by age, but yeah, no.
Thank you, though, for asking me something. And if anybody else wants to ask me or tell me something, I would love to hear it. Now, one of the things that has to do with mistakes that we make in the treatment of depression is that depression isn't only found in depressive disorders. It's also found in bipolar disorders, and it looks very similar. So when we look at people, the treatment of depression, and especially the treatment of depression in primary care, what we see is that there's an underdiagnosis of people who actually have bipolar disorders. So the most common depressive disorder of a severe type is major depression. And there's also persistent depressive disorder, which was renamed in DSM-5. It used to be referred to as dysthymia. Now it includes refractory major depression that doesn't go away, and what used to be the old dysthymia, which are subthreshold symptoms that don't quite meet the criteria for major depression. But you also see depressive disorders in people who have bipolar disorders. And one of the interesting things is that in the DSM-5, bipolar disorders moved into a different category than depressive disorders. We used to lump everything together and call that affective disorders. But one of the reasons for the separation is that it is much more difficult to treat bipolar disorders than depressive disorders. And the treatment is really quite different. So I just want to say that's one of the big caveats that I try to emphasize when I talk about it. You know, that you have to be thinking whether you're really treating just depression or whether you have a patient who's cycling through different mood states. The reason for the focus on depression is that there's probably no mental illness where you can better show negative outcomes for people with HIV than depression, other than maybe cigarette smoking, if you want to consider that an addiction. But depression is associated with increased morbidity and mortality, problems with adherence along the HIV care continuum, engaging in increased risk behavior for acquiring HIV, and just generally speaking, a poor quality of life. And I know others at this conference are talking about the fact that depression is the second most disabling condition in the world. It's considered more disabling than AIDS. And in the latest version that I looked at anyway, of the World Health Organization causes of disability, back pain was listed as #1. I guess that's the bane of the anatomy of the human body, is that our backs are really extremely vulnerable. And so there's more people disabled by back pain, but depression is second. So the way I like to think about major depression and differentiate it from just simply symptoms of depression is that it's as much a physical illness as it is a mental illness. And that complicates things when you have people who are already physically ill. So when you look at people with HIV infection or TB infection, or for that matter, heart disease or any problem, what you're going to have to wade your way through is the complexity of figuring out when someone has certain kinds of symptoms like weight loss and can't sleep and fatigue, they can't concentrate. Are those symptoms of depression, or are those symptoms of a physical illness? And this is not an easy question to answer, because gradually, as more research is developed, we're learning that there's a bi-directional relationship, such that depression is a risk for inflammatory disease, and inflammatory disease is a risk for depression. And this helps explain why we see so much depression in people with HIV and people with TB or any other inflammatory disorder. So that's important to know. And I just want to say, I'm on a one-person anti-stigma campaign. So I always mention that I myself have had major depression. And the reason I mention it is that I was practicing as a psychiatrist with no understanding of how physical major depression is until I had an episode at the age of 34. So this is more than half a lifetime ago. But what was interesting about that episode is that I started out with 6 weeks of somatic symptoms. Now, it was uncomplicated by medical illness because I was only 34. So, I went to my medical doctor. I thought I had a flu that wasn't going away. They found nothing on a workup, and they didn't think about depression. 6 weeks into this episode, I started to develop a depressed mood, and I began to cry. And then I made the self-diagnosis of major depression for on myself. I in medical settings, my internist, who was a very wonderful and conscientious guy, he's now retired, but I loved him, had no idea that I was depressed. And I think this is part of the problem in primary care. And once I had my own experience, I understood that major depression makes you feel so physically unwell that it's very easy to confuse physical and mental illness when people have both kinds of conditions. I also mention having this illness because it's highly stigmatized. It's highly stigmatized even among psychiatrists. We did a survey once in our psychiatric residence in New York City, and it was fine to be in therapy, but terrible if you took a medicine. So my own episode with depression taught me that the brain and the body really are just one system. And unfortunately, stigma causes us to create silos of care. And basically in medical school, more or less in the US, we try to teach medical students that mental illness isn't their job. And I think that's really a very stigmatizing attitude. Because when you think about it, the brain controls all of life's essential involuntary functions, such as breathing and heart rate, right? Your brain is telling your body what to do. Your brain is telling you automatically what voluntary physical actions you need to take to survive, such as I'm starving, I'm really hungry, or there's danger and I should run away. And the body is giving continuous feedback to the brain. My stomach is full. My muscles are tired from running. And strong emotions are expressed by the brain and the body together. So I don't know what expressions there are in Guyana, but in the US, we have expressions like, I feel a knot in my stomach for anxiety. There's a lump in my throat. That's another one that's more anxiety. Chills ran down my spine, fear, right? So we know intuitively as people that the body and the brain are acting in unison. But we stigmatize mental illness in healthcare training so that most providers emerge thinking that this is not their area. That's not an attitude that we can have if we're going to treat mental illness. The other thing that I wanted to say is that because we never have enough behavioral health disorders, when I do international work, and since COVID-19, I do this in the US as well, I think, how do we prioritize who really needs a referral to behavioral health? And I think for that, it's important to think about what's the difference between distress and disorders. And I think, honestly, that the research community is very confused about this. So when I look at evidence-based research and people doing implementation science research, I think people are really confused about what's the difference between distress and mental disorders. And why is that important? Distress is very common. It can occur in response to any adversity. And it doesn't often meet the criteria for a full psychiatric diagnosis. So you can use more supportive strategies. Whereas disorders, they cause more persistent subjective distress. They tend to cause functional impairment. They meet recognized diagnostic criteria in the International Classification of the Diseases or the DSM. And there are evidence-informed mental health interventions, such as medication and psychotherapy. So one of the things that I see taking place in a lot of international global research is that people don't make this distinction. They do, they do a screen, they get a certain score, and they say, oh, there's a person who needs treatment for depression. Then they use evidence that doesn't come from evidence that's been applied to people with distress, because the evidence comes from people with disorders. So this is an area of great confusion. Again, you're getting my opinions. The most commonly used instruments in screening for depression are the PHQ-2 and the PHQ-9, and that's because they're the easiest to use. You can find them online. They're translated into more than 80 languages, although they're not necessarily validated in all of them. They're very well studied in general medical populations, and they're easy to administer or self-administer. And they can be used to screen or aid. I shouldn't say and make a diagnosis, really aid in making a diagnosis. And some people use them to follow a patient's progress. Now, these are not the instruments researchers use. Researchers use more elaborate instruments to diagnose and follow depression. So you have to know this is really, these are tools in a clinical setting. So some people use the PH2Q. Usually if you're using that and it's positive, you have to follow it up with the PHQ-9. So the PHQ-2 asks two basic questions that are in the affective domain of depression. Have you had little interest or pleasure in doing things? Have you been feeling down, depressed, or hopeless? And usually it refers to the last 2 weeks. So it's not a day's worth of symptoms. And if the score is 3 or more, or you can use this as a yes/no questionnaire. If the person says yes to either of these, then you move on to the PHQ-9. In the National HIV curriculum that I told you about, it's great. There's a whole discussion about the specificity and sensitivity of these screening instruments. So if you really want to know how often we say someone's positive when they're not, or say somebody's negative when they really do have depression, you will find that information there. And then this is the PHQ-9, and that's where you start seeing, the items that are more physical. Feeling tired, poor appetite or overeating, trouble concentrating, moving and speaking slowly, and also it contains the question about suicide, which I know is a major focus about this conference. And one of the things we try to emphasize to people is that it's safe to ask somebody about suicide, because often there's a lot of fear to ask this number 9 question. So now I want to go back to my point about the differential diagnosis of depressive symptoms, that we really want to make sure we're not dealing with a medical problem. There are very high rates of medical problems in people with HIV and high rates of substance use. So we want to make sure that, let's say if someone's on a medicine that's making them depressed, we want to think about, do they need to stay on that medicine? And if it's yes, do we want to, treat the depression that the medicine is causing? There's a huge differential diagnosis for why people who are medically ill experience depression. And the other thing I want to say is that we know HIV causes cognitive impairment. With treatment, it's not so much HIV dementia, but milder impairment. But it's important to keep in mind, especially as with the aging HIV population, that depression is a major cause of cognitive impairment. So you really want to think about, in cognitively impaired people, are they also depressed? And think about whether treating the depression will get you some mileage. And again, I already made this point. We want to rule out bipolar disorder. And there are many therapies, and I don't really have time to review them all, but the ones that have the most evidence are cognitive behavioral psychotherapies, of which there are a variety, and interpersonal psychotherapy. And I think there's some talks about that here. And these psychotherapies have been used to treat depression, usually when it's mild to moderate, and sometimes in combination with antidepressant treatment. What I have found is that when people are very severely depressed, they can't concentrate. And so it gets harder to engage them in a psychotherapy. When it comes to antidepressant treatment, there's really no penicillin for depression. It's so sad to be in the field of HIV where we have such great antiretrovirals, and if we have the resources, we can, test the individual patient's virus and see what they would respond to. And now we have medicines where, that are fabulous to use, and they will handle most people who are treatment experienced and who used to have trouble maintaining viral suppression. But we're nowhere near that in psychiatry. And so when we use medicine, every person is their own little experiment. And we look at two outcomes. We look at response and we look at remission. Response is a reduction of more than 50% of symptoms in depression. And remission is really being better, having fewer or no symptoms. Why do we make this distinction? It's because of the risk of relapse of depression. When you have response and you're better, but not all better, you're at risk of full relapse back into major depression. So we try to get to remission where the patient has few symptoms in order to protect them from relapse of major depression. My favorite study to talk about antidepressants is the STAR-D study. That was a US-based study. It had no pharmaceutical company influence in it. It enrolled 4,000 patients, many of them with medical and psychiatric comorbidities, and it used a sequence of stepped care. So it started everybody out on an SSRI antidepressant. They picked citalopram, but it could have been any of them. Maybe they picked citalopram because it has lower drug interactions with medical medications than some SSRIs. Anyway, they used citalopram. And then if patients didn't get better, there were 3 other steps you could go to. And these are the endpoints, and hundreds of studies have been published based on the STAR-D study. I only want to make a simple point about it. If you are treating, if you are a non-specialist, if you are a primary care physician, and you are treating someone who really has depression, not bipolar depression, with antidepressants, you can achieve a full remission, acutely. This doesn't say what happens in the long run, in about a third. And you can get, response in about a half. That's for this first step. So when in citalopram, about 37% of the patients got all the way better, and about 49% had a reduction of 50% of their symptoms, right? But there are patients who can't tolerate the medicine they're given, so they drop out for that reason. It's not that the medicine isn't efficacious. They really can't tolerate it. So if you go to step 2 and you switch over, and I'm going to show you what the switch options were. But if you switch to another antidepressant, you still have a pretty good chance of getting a remission the second time around. So that's really the main point I want to make. In primary care, you want to make sure that if one drug doesn't work, patient can't tolerate it, the patient doesn't go in remission, try another one. Once you've done 2 good trials, and what is a good trial? A good trial is 6 to 8 weeks of a medication and going and starting usually in HIV with a low dose, because that's what we do with people with medical illness, but trying to go up to the full dose. Perhaps the biggest mistakes made in primary care are starting with a dose the patient can't tolerate, so they're totally turned off and never want to take another one of your pills again, or just staying at a low dose of medication where you're not going to get enough improvement because it's not the full dose. So we have the luxury with these medicines of working our way up. So it's important to know that you can switch from one antidepressant to another. It's hard to treat in primary care the things that are complex. So again, you have to think through how this works in your own setting in Guyana. But once you get to bipolar depression, psychotic depression, and risk for suicide or violence, or you're diagnostically uncertain, often it really helps to get consultation from a behavioral health specialist. These treatments may not be available in Guyana, but there are attempts to. There are a modest number of people who have refractory depression who don't get better with anything. And people are experimenting with brain stimulation treatments. I would say that's what most people who are at the cutting edge of treatment think is, in the long run, going to have the greatest promise. And we have 2 approved treatments now. Aside from, we have ECT, we also have vagus nerve stimulation and transcranial magnetic stimulation, and we're experimenting with hallucinogens like ketamine. And in any case, people with refractory depression suffer a lot. And so if you can get those people to behavioral specialty care, that's a really good thing to do when it exists. And the reason why the confusion exists is that bipolar depression accounts for the majority of time that people spend unwell. And it's estimated that about 3 in 20 patients diagnosed with depressive disorder in primary care actually have bipolar disorder. The treatments for bipolar disorder are totally different. And if you give an antidepressant alone to someone with bipolar disorder in their depressive phase, you can precipitate mania. And that's going to make you very unhappy because mania is much more difficult to manage than depression. There are in this curriculum, you can find information about screening for bipolar disorder. I'm not going to spend time here. And on average, these are more severe disorders, and you really need to teach patients a lot of skills. This is the one, mental illness where intensive psychotherapy has been shown to help. Managing up and down states for an individual who has them is a lifetime's worth of effort. Sadly, most of our illnesses are chronic. But I want to point out that one of the things I like to do to fight the stigma of mental illness is point out that it's among bipolar patients where you see some of the greatest creativity. So I don't know if you know about Alvin Ailey. He was an an African-American modern dancer. He had bipolar disorder, and he had also alcohol, drug use, HIV infection, and he died of AIDS. But he was a really good example of somebody who was, suffered from depression and multiple other things, who got addicted to drugs, who acquired HIV infection, both through having sex with men. He was gay, both through having sex with men and through injecting drugs. And anyway, his work lives on. So I think it's important for us to recognize that, we focus in psychiatry on all the negative things that mental illness brings, but mental illness is not only about negatives. It's about people. There are a lot of people out there with mental illness who are amazingly talented. Comorbidities are a huge issue, and alcohol and substance use probably the worst of the comorbidities. There are high rates, I'm not going to spend time on these slides, high rates of comorbidity, but the main point is what I have in bold here. When you have somebody with a depressive disorder who also has an alcohol and substance use disorder, you really need treatment for both. You can't expect to treat the alcohol and substance use and have the depression go away, or the other way around. The most important thing, it took me years to learn this, 2 disorders need 2 treatments. And the COVID pandemic has taught us that we're all in this together. We as healthcare providers, you know, we have suffered a lot through this pandemic. There's no us versus them. We're all in need of self-care, informal care, our primary care people to recognize what's wrong, and when to use behavioral health services, because they are limited everywhere. And that's my last slide. I'm gonna skip this. Okay. Yeah, I'm gonna go back to stop my sharing so I can see who's ever on and have at least a few minutes to talk. So I'm hoping somebody will ask me something or say something about their own experience.
So Dr. Jagmarian, you are actually working currently right now with HIV patients right now in Guyana, correct? I don't know if you have your camera on.
Hi, can you repeat the question? I'm here.
So I just wanted to know if you wanted to talk a little bit about your experience in Guyana.
Definitely, I can share briefly. So Guyana, to give you a quick idea, we have over 8,952 persons who are HIV positive, and the numbers have been going up slowly, in prevalence rate at 1.4%. And that has been constant over the past 5 years. And in terms of the patients, we do have like the vulnerable groups, minority groups, such as the key population, men who have sex with men, female sex workers, migrants, drug addicts, even the adolescents. And they all come with their challenges and mental health issues. Given that that particular population, and as Dr. Cournos would have pointed out in her presentation, they're already susceptible to so many stigma. And having worked in so many countries, she can relate and tell you that some of those countries, there is heightened stigma towards the key population. Not only that, there is discrimination and they're highly marginalized. COVID-19 too hasn't been anyone's friend, especially towards persons living with HIV. Many of them would have had issues related back to their access to medication, access to job, transportation to go and get simple medication to maintain their viral load and suppressed. And so we would have had cases, or a social worker would have mentioned to us that for some of the persons are suffering a lot from depression, anxiety. They're worried about the vaccine, taking the vaccine, how it impacts them. And so one of the measures we would have put in place is trying to provide this one-to-one counseling. It is challenging given the amount of persons who are HIV positive, but we've been reaching out to them, doing small one-on-one counseling, group sessions. Those of who we deem that can be a little bit more, they're affected, and we need to take a lot more time with them. We've been spending time with them. So in Guyana, yes, like other parts of the world, we are, our persons living with HIV do experience lots of mental health issues and challenges, but we've been working with them. I'm happy to say that we have especially a cadre of social workers who are specifically trained with HIV and to provide that level of counseling and support as it relates to mental illness and HIV. Something that even though you may graduate from the university with a background in social work or what I've been doing it a number of years, we try to have you trained specifically in that area. And not only in terms of the geographic too, and the key population. As you're aware, there's a large influx of migrants in the country coming from countries that they've been experiencing a lot of prejudice and opposition with challenges, such as Venezuela and Brazil from the borders. And so they too come with their different level of mental issues. So yeah, I just want to say thanks to Dr. Cournos too for sharing her presentation with us. I know it's been impactful. We've learned a lot from it, and I think we would welcome this. Maybe if we can have it twice a year. Do come with us and share with our colleagues. I would love if you can talk to some of our social workers too. I'm not sure if I am supposed to moderate if anyone has any question. Please check.
Thank you so much for giving me that background. And I think clearly your experience is the experience everyone has, right, with HIV populations. They are very complicated from a mental health perspective.
Yeah. I'm not seeing anyone in terms of asking questions. Most of them are thanks. So I know definitely you did a great job. We want you back. We want to spend a year with us, Dr. Cournos.
I actually had one question. So I think that you mentioned before, and this is like, we've actually talked a few times today about depression and bipolar disorder. So do you think there's, do you have a question also? But there's been a lot of talk about how there is this misdiagnosis a lot of times. Why do you think that is, that people are more commonly diagnosed with depression as opposed to bipolar?
Yeah, I think this misdiagnosis, I talked about specifically misdiagnosis in primary care. I think there are probably a number of reasons for it, but one reason is that often when people are manic, that's not when they wind up in primary care. They may wind up in, if they're causing enough trouble, they could wind up, being picked up, at least in the US, by the police and taken to an emergency room or a psychiatric hospital. No one's going to take them to a primary care physician in that state. The ones with milder cases of mania, when like hypomania, many of them like those states and think that absolutely nothing is wrong. So what happens is that you see much more care seeking in the bipolar population in the depressive phase. And most bipolar patients spend most of their time depressed. So that's the majority of time. So because bipolar patients are mostly depressed, well, not all, but most, and because they're most likely to seek care then, that's when they're presenting, in a depressed state in the primary care setting. And then I can't tell you the number of times that I see people with a diagnosis of bipolar disorder, or where the diagnosis doesn't match the medication treatment. And that's true for a whole variety of different illnesses. But if you have somebody with bipolar disorder and with that diagnosis and they're on an antidepressant, either they don't have bipolar disorder or they're on the wrong treatment. So it's true the other way around. When you look at the label bipolar disorder, it's, bipolar disorder on an antidepressant, that's a key to a clue that something is really wrong with what's going on. Either you don't have the diagnosis right. Sometimes it gets confused with things like PTSD. So it's hard because psychiatry doesn't have enough biological markers yet. Sad because, for those of us who work in the HIV field, we're so lucky about the progress we've made. And if we look at some of our comorbidities like hepatitis C, and I don't know if treatment is available for hepatitis C, but we can cure it. That's amazing. That's a revolution. But there haven't been any revolutions in psychiatry yet of the same kind. The kind that really would help you instead of playing around, should I try this, should I try that? Well, I'm waiting for the revolution to occur, where we would really understand what's wrong diagnostically through more biological markers and what medicine to give through more biological markers. I mean, there are people who do research on this, but none of it is translatable right now. The only thing that you can translate right now into clinical care, and most people don't do it, is you can look at the cytochrome P450 enzyme system and see if people are fast or slow metabolizers of drugs. So I just want to say, I did some work in many sub-Saharan African countries and in general African populations, and I don't know how this would translate into Guyana populations, don't need as high doses as US populations do of a lot of psychotropic medication because they metabolize these medicines more slowly. Now, it varies a lot by individuals, And there are some countries where there are groups of very slow metabolizers and very fast metabolizers. But just to say that that's about the only biological thing that we can look at, and you need the resources to look at it, can you, but I have some colleagues who do like to look at that when they're dealing with patients, so they know maybe the dose isn't working of a medication because it's too low and they metabolize it fast. It's just something to keep in mind, even if you can't do it. That one of the reasons we start slow but try to work our way up to the full dose is that if we don't know how someone's metabolizing a drug, we don't know when we're getting to a good blood level.
Thank you.
Thank you so much for that. Is there any other question for Dr. Cournos?
So we have a question from the audience. Can you define bipolar disorder again for the audience?
Can I look at that question or no?
Yes, definitely, Doc. Go ahead.
Chat. No, I haven't seen.
Oh, it's from the physical audience that's here in Guyana.
Oh, okay.
So we had a question from an audience member who's physically here. If you could define bipolar disorder. Yeah.
And can I ask what the question is? Because I can't see it.
Can I come over? Do you want to speak? You could speak into the thing. Oh, I think that she just wanted the definition. So for you to define what bipolar disorder is again. So, yeah.
So the difference between what makes somebody bipolar disorder is the ability to switch from a state of being in a low mood to a state of being in a high mood. And the way it's just not like, oh, gee, I'm having a really happy day, is that some of the things that start to happen won't happen in normal people. So some of the obvious things, like I'll just use, since I'm in my anti-stigma campaign, I have a grandniece who's having, I think, a full manic episode, but thinks nothing is wrong with her and won't go for care. This is, of course, a typical situation. She's talking out loud to herself. When her parents ask her, why are you talking out loud? She says, because the thoughts in my head are so fast that I have to write them down. That is not something people will normally complain about, that the thoughts in their mind are so, fast that they have to write them down. Most of us don't have racing thoughts. Another symptom that she has is doing reckless things. So sometimes at night she'll go out and she'll, spend the night outdoors with homeless people who she doesn't know. Whether that is reckless, her mother thinks it's reckless, but the mother doesn't believe she has bipolar disorder either. So that's another problem. So it's really usually a group of people who don't need, they have a lot of energy. They don't need the usual amount of sleep. Sometimes they're happy, sometimes they're irritable. It really varies a lot. Sometimes they become happy and then get irritable. And there are some people who are both mental health researchers and providers who've written about bipolar disorder. They study the disorder and they have it. Like the Kay Jamison book, Touched with Fire. She's someone who has studied bipolar disorder and she has bipolar disorder. And she can explain these different states. The states when she's depressed and down, the states when she is, in an elevated mood that allows her to work well and creatively, and the state she can get to where she's lost control. Now her mind is totally racing. So this is happening to my great niece. She's normally a very good student, but now she can't concentrate anymore and she's failing her courses. That's very unlike her. So it's not her intelligence. Her brain is too disorganized to concentrate. So it's those more functional things and assessing the severity of them. Whereas a person like me, who's only been depressed, I have my happy days, but I've never had a reduced need for sleep. When I was depressed, I couldn't sleep, but I hated it. I never get into those creative states that I have bipolar friends. They're much more imaginative than me, so I don't have that kind of imagination. Anyway, it's just a very interesting disorder in which people, think fast, do fast, but get into trouble. I don't know if that explains.
Oscillation between those two extremes of mania and depression.
Yeah, they cycle.
Is that clear to you? Does anybody else from the audience have a question? From the live audience or the Zoom audience?
So there are
Yeah,
no
thank you.
if there are no other questions, guys, I would like to ask Dr. Cournos to share a few brief words of closing remarks, and advice towards the Guyanese populace and healthcare workers. What is it we can do to help with mental health, especially to the HIV team? Thank you.
Yeah. So I would say in closing that we know that stigma is the major barrier. We know that there are people in this audience who've had experiences and have family members with experience of mental illness. I personally always declare that I have a mental illness, but major depression isn't the only one, but I won't go into the others because, you know, I think those of us who are care providers need to look at our own stigma about these disorders. That's our major barrier. I think primary care has a major role to play because that's where people go. So, and when you're a primary care provider, you have to look at your own stigmatizing attitudes towards mental illness and try to learn how to be comfortable. You know, we're frightened when we see somebody behave abnormally. And unfortunately, in most of our programs, we haven't learned how to calm ourselves down. So we need to overcome our fear and our stigma. We need to understand that all of us are providing mental health services. During COVID, it was clear. If a case manager was following a COVID patient, not trained clinically at all, reached out to a COVID patient and said, "How are you doing?" That was a huge mental health intervention because the patient felt, wow, this place is temporarily closed down, but the person who knows me well is still reaching out to me to find out how I am. That makes me feel good. Everyone is doing mental health, whether you think you're doing it or not.
Thank you so much. Okay, thank you for you and Dr. Jagnarian, and everybody have a nice day. We'll